Hello everyone, we are back with the second lecture of PCOS or Polycystic Ovarian Syndrome. In the first lecture, we talked about the definition and how to basically say that the following patient is having PCOS. Today, we are talking about clinical features and diagnosis. Now, as I always say, whether we are actually seeing a patient or we are appearing in some theory exam or in some practical exam, it should always be a clinically oriented approach. So, if we talk about diagnosis, it has both clinical features as well as investigations. Clinical features. Clinical features are always divided into two parts, symptoms and signs. Symptoms are those which the patient tells in the history. You just end with an open question. How are you feeling? What brings you here? So, the things which the patient says include the symptoms, but the things which you as a clinician see are signs. So, I have involved both symptoms as well as signs as clinical features. As I talked in my first lectures, menstrual irregularities are mostly the presenting symptom. Infertility, manifestations of androgen excess, hirsutism, right? I hope you remember, and other endocrine dysfunctions which we have to look for. Symptoms classically become apparent within a few years of puberty. Why is this line important? Because once a female attains puberty, initially few years, the cycles are always irregular because they are anovulatory cycles, and we cannot stamp an adolescent as PCOS. Generally, we delay the diagnosis by 18 years. Now, clinical features. Menstrual dysfunction range from amenorrhea to oligomenorrhea or episodic menometrorrhagia, and because it is menometrorrhagia, so iron deficiency anemia. What does that mean? We have already studied these terms in our AUB lecture. So, here amenorrhea means absence of periods for 3 consecutive months. Very important. Secondary amenorrhea is told when there is absence of periods for 3 consecutive months, and oligomenorrhea means less than 8 menstrual periods per year. So, the patient will say, I don't have periods regularly. Then what is the irregularity that we have to look for? Either amenorrhea or oligomenorrhea or menometrorrhagia. What is menometrorrhagia? What happens? There is a period of anovulation, so there is a period of amenorrhea, then suddenly there is a period of heavy bleeding because again the estrogen rise is not there. So, disturbed cyclical changes leads to menometrorrhagia, heavy bleeding after a period of amenorrhea. But what happens? Because she bled heavily, then there is anemia, which is generally iron deficiency anemia. Hyperandrogenism. Hyperandrogenism has 3 features: hirsutism, acne, androgenic alopecia. I have talked about them in the first lecture. All of 3 are important, but most important is hirsutism, which we will have to look for. What is hirsutism? Look here, facial hair. Hirsutism is defined as coarse, dark, terminal hair distributed like a male pattern. So, male pattern hair distribution in a female constitutes hirsutism. And as I told, there is a Ferriman-Gallwey system in which a score of more than 8 was significant. I hope you remember from the first lecture. So, here in a male pattern, so what is the male pattern? Beard like, mustache like, on the abdomen, below the umbilicus. The female says that I have to regularly go for the removal of the hair. Sometimes you cannot see because she has already removed it artificially. So, we have to ask that whether you have a male pattern hair on your face, on your tummy. Acne vulgaris. It is a frequent finding in adolescents. When a child turns into adolescent, there are acne vulgaris, but In PCOS, it is particularly persistent or late onset. They don't go only, they are there for long, for months altogether. Late onset acne vulgaris and persistent acne are a feature of androgen excess in patients of PCOS. Alopecia, hair loss, but there is a pattern. Progressive hair loss slowly and is characterized by diffuse thinning at the crown, hair at the crown with preservation of the frontal hairline. Generally male pattern baldness is what? The frontal hairline recedes, but here the loss starts from the crown. So, progressive hair loss slowly and diffuse thinning at the crown. Now, endocrine dysfunction, this we need to know. We need to investigate the patient for these endocrine dysfunctions which are generally associated with PCOS. Insulin resistance, that we have talked about in the pathophysiology itself, that sometimes it starts from insulin resistance itself. Hair-N syndrome. What is Hair-N syndrome? H-A-I-R-A-N. H-A-I-R-A-N. Hyperandrogenism, insulin resistance and acanthosis nigricans. I will be explaining it in a while. Hair-N syndrome is associated with PCOS. Hyperandrogenism, insulin resistance and acanthosis nigricans. The association among insulin resistance, hyperandrogenism and PCOS has long been recognized. Sometimes it is the precipitating factor, sometimes it is precipitated. So, it is a cyclical pattern. What is acanthosis nigricans? It is a skin condition characterized by thick grey brown velvety plaque like structures seen in the flexor areas. What are flexor areas? Like this: back of the neck, axilla, inframammary creases, groin. Wherever there are flexor creases, there you can find structures like these. What are these? These are thickened grey brown velvety plaques. Why do they happen? They happen because insulin resistance leads to hyperinsulinemia in the body. Since there is resistance, the insulin is not working. So, body makes more insulin so that it works, but it does not work because of the receptor problem. So, body has more and more insulin, which leads to keratinocyte and dermal fibroblast growth, producing the characteristic skin changes. Now, impaired glucose tolerance and type 2 diabetes mellitus. Impaired glucose tolerance are those patients who have a range of deranged glucose levels, blood glucose levels, but still they are not diabetic. It's sort of pre-diabetic, and type 2 diabetes mellitus is a florid diabetes mellitus. So, the prevalence of impaired glucose tolerance and diabetes mellitus is approximately 30% and 7%. So, if you investigate these patients with some glucose tolerance test, you give them glucose and then monitor the blood glucose, you will find that 30% of the PCOS patients are already in the impaired category and 7% of them have already landed up in diabetes. Why? Beta cell dysfunction. What are beta cells? These are the cells which are present in the pancreas and responsible for the insulin regulation. So, beta cell dysfunction, which is independent of obesity, has been reported in patients of PCOS. So, a patient with PCOS have hyperinsulinemia, the patient has insulin resistance and diabetes altogether. Dyslipidemia, lipids. So, we have low density lipoproteins, high density lipoproteins, triglycerides and cholesterol. These are all the things which make our lipid profile, and we know that HDL is the best of all of them. It prevents the illnesses. But here what happens? LDL level is increased, HDL level is decreased, triglyceride increases, cholesterol increases. So, all the lipids which are creating problems of basically cardiovascular disease, they all increase in PCOD and the healthy one decreases. So, increased LDL levels and triglycerides, elevated cholesterol to HDL ratio and decreased HDL level. Obesity. Obesity is a frequent accompaniment with PCOS, and if we monitor the waist to hip ratio, this is the patient. So, if we monitor the waist to hip ratio, it is more, that means pear shaped structure, waist is more. Elevated BMI, body mass index, what is this? Weight upon height in meter square. So, the weight increases, so BMI increases. This reflects a android or central pattern of obesity, which is an independent risk factor for cardiovascular disease and insulin resistance. So, central obesity pattern, android like obesity, which is independent risk factor for cardiovascular disease and insulin resistance. Obstructive sleep apnea. There are 30 to 40 fold more chances of developing obstructive sleep apnea in patients of PCOS. So, PCOS is basically a whole syndrome where everything is leading to insulin resistance, cardiovascular risk, diabetes, deranged lipid profile. Metabolic syndrome. What is metabolic syndrome? It is characterized by insulin resistance, obesity, androgenic dyslipidemia and hypertension. It is associated with increased risk of cardiovascular disease and type 2 diabetes. What I am talking about since last few slides, that everything is problematic. Insulin resistance, obesity, androgenic dyslipidemia, hypertension, leading to cardiovascular disease, diabetes. And the prevalence of metabolic syndrome is approximately 45% in women with PCOS as compared to 4% in age adjusted controls. So, if you meet a patient of PCOS, you should look for the metabolic syndrome, that whether the patient is pre-diabetic or diabetic, whether she has already developed the whole syndrome. If not, then we should counsel that you may develop these problems. In women with PCOS, the risk of endometrial cancer is increased by threefold, that we have already read. Endometrial neoplasia, why? Because of unopposed estrogen. In cases of PCOS, there is more estrogen, there is no progesterone, and because of unopposed estrogen, endometrial hyperplasia occurs, and at some point of life it can convert into neoplasia or cancer. Infertility or subfertility is a frequent complaint. Why? Because of anovulatory cycles. We have read that because of that pathophysiology chart, if you remember, there is a complete cycle and then the ovary goes into anovulation. When there is no ovulation, the patient presents with infertility or subfertility. Now, pregnancy loss. Even if you give the treatment to the patients and they become pregnant, even then they experience an increased rate, 30 to 50% of early miscarriage as compared to 15% in general population. If we talk about first trimester spontaneous miscarriages, the general population they have 15%, but PCOS patients have an increased risk 30 to 50%. They have 2 to 3 fold higher risk of gestational diabetes if they carry on. If there is no first trimester loss, then when they reach term, there are increased chances of gestational diabetes, pregnancy induced hypertension, preterm birth, perinatal mortality of the baby, which is unrelated to multifetal gestations. Even if she is having multifetal gestation, it does not mean that morbidity was because of that. It was because of PCOS. So, gestational diabetes, pregnancy induced hypertension and preterm birth. Psychological health. We have read so many things, that she may be obese, she may be having acanthosis nigricans. If she compares herself with the peer group, she is not having regular periods. There are so many things. So, it gives them various psychosocial problems like anxiety, what will happen to me, whether I will develop the metabolic syndrome, what will happen to my life, depression, low self-esteem, I don't look good, such sort of things they actually come across. and reduced quality of life with negative body image. So we need to counsel them on these things also. Now, before going to the actual investigation and diagnosis part, I would like to reinforce the female reproductive axis which we have talked in the menstrual cycle itself. This is the hypothalamus in our body, then this is the pituitary, this is the ovary, and this is the end organ which is the uterus. Now what happens? We are talking in a normal female who is not having PCOS. So there is pulsatile release of GnRH. This is very important. Pulsatile release of GnRH to the pituitary. So pituitary releases both LH and FSH depending on the time of the cycle. LH and FSH work on the ovary, on the granulosa cells and the theca cells. So under the effect of FSH and LH, follicular maturation starts in the ovary and the ovary produces estrogen, progesterone and inhibin. Inhibin goes back to the pituitary and inhibits FSH. Whereas estrogen, progesterone, testosterone which were released from the ovary, they go to the end organ which is the uterus and it prepares for possible pregnancy. But here comes the role of positive feedback and the negative feedback. Negative feedback is there in most of the cycle. I am talking about the menstrual cycle. Estrogen, progesterone and inhibin reduce GnRH, LH and FSH release, but only in the mid cycle because of the positive feedback of high estrogen, it stimulates GnRH and there is LH surge. In the pathophysiology of the PCOS, we have studied that LH increases in patients of PCOS because of the non-pulsatile release of GnRH. So here this is a normal physiology that what happens from hypothalamus to pituitary to the ovary, uterus and the feedback system. Keeping this thing in mind, we will go towards the diagnosis because in PCOS the cycle is broken. And what is anti-Mullerian hormone? Anti-Mullerian hormone, what happens? A classic polycystic ovary contains 2 to 3 fold more growing pre-antral and antral follicles. What happens in a normal ovary? In a normal ovary there is a pre-antral follicle, then an antral follicle and they produce something which is called as anti-Mullerian hormone or AMH, and this is normal for every ovary. But what happens in a PCO, polycystic ovary? There are 2 to 3 fold more pre-antral and antral follicles giving rise to more and more AMH. Within the granulosa cells of these developing follicles, AMH is produced. So in patients with PCOS, the AMH level is 2 to 3 times as compared to a normal patient, a normal female. So AMH, what is AMH? AMH is produced in the granulosa cells from the pre-antral and antral follicles basically. It is normal for a normal ovary, but because in a polycystic ovary there are 2 to 3 fold more pre-antral and antral follicles. So AMH levels are 2 to 3 times increased. We should keep this in mind. Now coming to this chart, the patient comes to you. Patient will not say that I am having PCOS. No, she will say I am not having my periods. I didn't have periods for last 3 months, or if they come they are very heavy. So there will be signs of amenorrhea or oligomenorrhea. Then you will have to diagnose whether it is any other condition or is it PCOS. So we cannot diagnose for PCOS. We will have to go for the symptom. Here it is oligo or anovulation. What are the causes of oligoovulation or anovulation? First and foremost is PCOS, right? But others are hyperthyroidism, hypothyroidism, hyperprolactinemia, hypogonadotrophic hypogonadism, and premature ovarian insufficiency. We will have to keep all these 6 differential diagnoses in mind, and only after that we can reach to a diagnosis. PCOD is basically a diagnosis of exclusion, where we have to exclude every other thing. Thyroid disorders, prolactin disorders, hypogonadotrophic hypogonadism. What does that mean? That the axis is not working. GnRH release, FSH release, LH release is not there. And premature ovarian insufficiency, that means before menopause, before the actual time of menopause, the ovary has started declining in the function. So what are the tests available in cases of PCOS? These are not the tests for PCOS itself. If a patient of oligoovulation or anovulation comes, what happens to the total testosterone level? T means testosterone. As I talked about this in my first lecture, generally free testosterone is more specific, but because of the changing methods of each laboratory, the testing of total T level is more and more like we can rely, it's more reliable if we go for total testosterone level and not specifically for free testosterone level. So total testosterone level is mildly increased but not too much increased. DHEAS level, dehydroepiandrostenedione levels, I have talked about this in my first lecture in the pathophysiology. Mildly increase, maybe or may not be. LH to FSH ratio is typically more than 2:1 because LH is increased much more as compared to FSH. And AMH level, as I was talking in the last slide, these are increased. So if you see, if this pattern you see, then yes, the patient is having PCOS. What about TSH? TSH is thyroid stimulating hormone. So if thyroid stimulating hormone levels are decreased, what does that mean? That means that the patient is already having much more of T3 and T4 in the body, and that's why TSH levels are decreased, which is a condition hyperthyroidism. And opposite is hypothyroidism, where there is decreased T3 and T4 level, so TSH level increase. Now prolactin level is increased in hyperprolactinemia. Mild hyperprolactinemia is generally associated with PCOS, but grossly elevated prolactin levels are not associated with PCOS. Now if we go for FSH, LH, estradiol levels in the body, and we find that all of them are decreased altogether. That means there is decreased FSH, decreased LH, and so the ovary is not producing estradiol. That means it is hypogonadotrophic hypogonadism. And if FSH and LH levels are to increased, but estradiol are decreased, what does that mean? That the pituitary is sending the signals, but the ovary is not working. So FSH level increases, LH level increases, but there is no estradiol formation. So that signifies premature ovarian insufficiency. So just by doing these tests, you can actually make out that what your patient is suffering from. Now comes causes of hyperandrogenism. She came to you and you find out that there is hirsutism, right? You want to find out whether it is PCOS or something else. So right now I will not be talking about PCOS because I have already talked in my previous slide. Late onset congenital adrenal hyperplasia. So 17 hydroxyprogesterone levels are increased. If it is an androgen secreting ovarian tumor, so total testosterone levels are too much increased, more than 200 nanogram per ml. It was mildly increased in cases of PCOS, but if it is heavily increased, think about an ovarian tumor. Androgen secreting adrenal tumor, DHEAS level highly increased. They may or may not be increased in PCOS. Cushing syndrome, the cortisol levels are increased, and if the patient is taking exogenous androgen because of some other reason, so go for toxicology screen and you will find increased levels. So the tests are altogether different in cases of hyperandrogenism. Now summing up the test for PCOS. If somebody asks you just sum up the test for PCOS, or you have a question in the exam that write down the test for PCOS. So serum levels of FSH, LH, TSH, prolactin, total testosterone, DHES, 17-hydroxyprogesterone, 2-hour glucose tolerance test, HbA1c, lipid profile. These are important. Why HbA1c, lipid profile and 2-hour GTT? Impaired glucose tolerance, diabetes mellitus and dyslipidemia, right? We have already studied all of them. Measurement of the BMI and the waist to hip ratio and blood pressure. We want to rule out the metabolic syndrome as well. So, serum levels as well as measurement of blood pressure, measurement of obesity, waist to hip ratio, everything should be included if you are writing the test panel for PCOS. Now, something about virilization. Since we are talking about hyperandrogenism, always look for acne, hirsutism, amenorrhea, clitoromegaly. Clitoromegaly is a part of virilization and not hyperandrogenism. Androgenic alopecia, decreased breast size, deepening of the voice, changes of the voice, we do not notice it in PCOS, and increased muscle mass. So, if you find that the patient is having virilization, then the test panel is different. What is that? You were looking for androgen excess signs and you come across that the patient is having virilization. So, if the patient is having virilization, total testosterone, DHEAS, 17-hydroxyprogesterone, and then go for imaging, look for tumors. But if there were no signs of virilization, then you proceed, whether there was anovulation or whether the patient was having regular menses, you will have to ask about the menstrual history. If you find oligomenorrhea, amenorrhea, that means the patient is also having anovulation. Now what to do? Thyroid function test number 1, prolactin, testosterone, 17-hydroxyprogesterone. Order these tests. If thyroid comes out to be abnormal, treat the patient accordingly. If they come out to be normal, then consider PCOS, congenital adrenal hyperplasia, anovulation. If prolactin turns out to be high enough like more than 100, go for pituitary imaging. Whether there is microadenoma, macroadenoma, you will have to look for the source of prolactin. But if it is normal or mildly raised, think about PCOS or congenital adrenal hyperplasia. Now, if the patient was having regular menses, then do not go for TFTs and prolactin. Go for total testosterone and 17-hydroxyprogesterone, which I left here. So, if the testosterone comes out to be less than 200 nanogram per deciliter, that means it was increased, yes, but it was not too much increased. So, think about anovulation and then you come back to this PCOS CAH. If it is more than 200, then go for imaging, look for some tumor. Similarly, 17-hydroxyprogesterone, if it comes out to be less than 200, then it excludes the late onset congenital adrenal hyperplasia. But if it is more than it, then you will definitely have to go for an ACTH stimulation test. Why? Because after giving ACTH stimulation test and the target level is 1000, if it is less than 1000, it's okay, it is heterozygote carrier, but if it is more than, then definitely you are dealing with something late onset CAH and the patient has to be managed accordingly. So, if you see the signs of androgen excess, don't stamp PCOS directly. Go for this flow chart and always you will have the diagnosis in your hands. Endometrial biopsy, when to do, when not to do. Most of the investigations part I have already covered, but just to complete your long answer questions. Endometrial biopsies are generally not indicated in less than 45 years of age, but if there is abnormal bleeding in any woman more than 45 years of age, then we take a biopsy. In case of younger women, but history of unopposed estrogen exposure such as obesity, PCOS, and failed medical management, that means the patient was having persistent bleeding even after giving medications, then go for biopsy and look for some other pathology. Now sonography. As we talked in the Rotterdam's and modified Rotterdam's criteria, there were three things: menstrual disturbances, which we have talked, androgen excess, I have talked. Now sonography. This is a classical picture of polycystic ovary. Small follicles, can you see? Necklace pattern or string of pearls appearance. So in Rotterdam's criteria, more than 12 follicles. But in modified Rotterdam's criteria, more than 20 follicles, 2 to 9 mm size and ovarian volume more than 10 ml. So if you see any such picture in the transvaginal or transabdominal sonography, but modified Rotterdam criteria are on transvaginal sonography with a probe of more than 8 megahertz. So this is a classical polycystic ovarian pattern and you can include it in the diagnosis. Measurements of insulin resistance and dyslipidemia are generally not done. We are doing this just to warn the patient that you can land up in trouble. So I have talked about OGTT, oral glucose tolerance test, HbA1c level and lipid profile. So they are generally not required to diagnose the condition, but they monitor the patient. With this, I am finishing off this class of diagnosis, investigations, clinical features, and we will meet with the treatment class in a few days. Thank you.